How's it going, Modern Manual Therapy viewers? Dr. E here with an MMT TV Q&A. This question is from Dr. Michael Moreau, and he says, "Hey, I recently purchased your knee terminator. Thanks for the support. But I wanted to inquire about hip OA. I currently have a large caseload of patients with severe articular changes at the hip. I've used Mulligan, hip IR and ER oscillations, repeated extension and lying, wall shifts, etc., but don't seem to see tremendous changes in range of motion. Could you offer suggestions on patients you have treated that present in this fashion? Thanks for your time, Mike." Hey Mike, thanks for letting me answer this on a video. So that's a really good question, and I think sometimes we get hung up on range of motion as PTs because it's one of the things that we can change, right? It's one of the things we all look for. We all look for mobility, motor control, strength, to put it simply, and we try to improve those things where there are asymmetries or deficits. In terms of an older population or even a younger population with significant hip asymmetries, I think anatomy is important to respect, especially with the hip. Sometimes people have bony end feels, like real bony end feels. And I'm not talking about tone, because it's always hashtag tone or bone Tuesday. But I'm talking about changes that you can't change no matter how much manual therapy you apply. If there is a significant bony asymmetry, or they're an older individual with a ton of adaptive changes, true adaptive shortening, they are a multi-directional dysfunction, meaning they have moderate to severe loss of range of motion in all planes, particularly at the hip, then you might not be able to change it significantly. I wouldn't be too focused on that. What I would be focused on is just changing their function, changing their strength, and changing their pain perception. A good example of this is a younger guy I treated who was actually a local PT, and he came to me for hip pain. He had a few injections and things just basically stopped working. He couldn't run marathons anymore. He had significant asymmetries in his left hip in all planes, bony end feel. He also had knee limitations, tibial IR limitations, and ankle dorsiflexion limitations. We were able to work on all of those and get them symmetrical to the other side, or as close as possible. But we couldn't change his hip at all, no matter how much manual therapy I applied to the hip, the lumbar spine, repeated loading strategies, needling, wrapping, etc. Everything changed but his hip. However, everything else around that area that enabled him to accept load in a threat-free manner over the course of an entire marathon, that was restored. So I wasn't able to change his hip, but I was able to change his pain perception and his function. Going back to older individuals, again, you could always look at the lumbar spine, you can look at the knee, you can look at the tibia, you can look at the ankle. You might be able to make more rapid changes in joints above and below. But again, if they have significant range of motion limitations in all planes and not just in one plane, they're more likely to be a slow responder. So don't look for the same amount of significant improvement you can get with a rapid responder within 1 to 2 sessions, unless those 2 sessions are months apart. You may eventually be able to increase your range, but it's going to be gradual. Remember, true length changes, if possible, happen like hypertrophy, which is slowly over time and with continuous loading. The most important thing is to change their pain perception, and I would say for older individuals, you probably need to work on hip extension more so than other directions, because that will change the extension moment at their lumbar spine, and potentially that would prevent peripheralization if some of their hip pain is coming from the lumbar spine. So I hope this answers your question, and I think it's important for us to be patient, especially when it comes to older individuals. They may not have the rapid range gains, at least immediately, or it may not even be possible, but someone who's a slow responder or a non-responder in mobility can still be a rapid responder in pain, and that's the most important takeaway, because you can still rapidly change pain with education and modulatory techniques, because that is an output and that is easier to change in this case than true tissue changes. All right, so thanks for submitting the question. You guys can always feel free to email me or reach out on any of my social media channels. Please subscribe to Modern Manual Therapy on Instagram, Facebook, and YouTube. If you subscribe via email, you get our weekly newsletters with our daily blog updates, along with a discount for edgemobilitysystem.com, and check out all our products and seminars on that. Have a great day.